it was just so unusual, so unusual.
It's beautiful. That is
Oh,
so
you did. I guess I do have this. These are not. Well, huh.
You back in the office on Thursday?
Well, I mean, Wednesday, I'm going to have my test early Wednesday morning and then office at 10 o'clock on. Well, I thought they were on here, but I guess they're not. I know they're on my iPad, so
yeah.
I'll just see some of them
Okay.
afterward.
Yeah, that'd be great.
If you, but you spend a long time. No, I'm not seeing me on here anymore.
No.
Oh, there we go. Yeah.
Just to let you know, we are recording and we have gone live on Facebook, but we still have a couple of minutes. And so that'll allow people on Facebook to see the notification that we've gone live, and we'll get some more viewers on there as well.
Okay. And you'll let me know when I'm to start?
Leah's going to do an introduction for you. Yes.
And so then I turn the lights off completely when we start, right? Turn it off?
Yes. Yes.
Gotcha.
No.
She told me something about a dark room when we first got on, didn't she? I mean, I swear she did.
You looked like you were in a completely black room, ink black.
Yeah, I'm just going to give a super brief introduction, and just so I can turn it over to you.
Okay.
And then give you your go.
And then who do I turn it back over to you when I think it's done, or what? Or just end it? Or how do I?
Yeah, we'll kind of come on at about, I don't know, after your video or after your comments after the video, when it looks like you're about wrapping up, we'll say, okay, we'd like to open it for questions, or you can open it for questions. And then we usually jump in and say, okay, we're thankful that, Dr. Dixon was here. So we'll close.
Okay, cool.
We'll be with you the whole time.
Okay, but after the video, I'll just sort of say, are there any questions, and go from there.
Mm-hmm. And we'll be monitoring to see if anybody's doing this. Some people know how to raise their electronic hand. Some people are doing this. We're all new to this. So
okay,
we keep it pretty casual.
Good.
I don't know if you remember the store Hastings, but they would always play that song when it was time to close. Happy trails to you.
Oh,
Yeah.
I sometimes wonder if we should start humming that.
Yeah. I mean, that's crazy. The technology put Hastings. You think Hastings would never go out of business?
Right.
That's such a bang up business, and now they're gone. That's crazy.
I still miss getting to see books and magazines and that kind of thing. Somebody played music there. Was that at the hospital?
Yeah, we have every time those chimes play, it's a reminder for us to wash our hands.
Well, please wash your hands then, and Leah will get the class started.
That's right. All right. Looks like it's time. I know we'll have a few more people joining us. Gina, do you want me to wait, or do you want me to start on time?
Go ahead and start on time. We don't want to keep the doctor longer than he has to stay here.
Okay, sounds good to me. Welcome to the Life Quest of Arkansas Facebook page and Zoom classroom. We are here with Dr. Jerry Dixon, And he's joining us from Arkansas Heart Hospital, which is an important sponsor of LifeQuest and has been a great participant of our programs for a couple of years, and especially this summer with Chef Nicole and Dr. Myers. And now we have Dr. Jerry Dixon, who is a board certified general surgeon, which means he can diagnose, treat, and operate on just about any part of you. He's good for what you got, and we're going to let him tell you a little bit about his background and where he's taught us from today. And he's got a special presentation on a particular part of the body that I'm going to let him tell you about in detail. Thank you, Dr. Dixon.
Hello and welcome. It's sort of unusual times with the COVID. And I'm coming off of a 2-week RV COVID-free vacation. I got to go to Utah and saw the 5 national parks in Utah, ended up in the Grand Canyon, Lake Powell. And so I'm in my quarantine before I have to be COVID tested to start practice again. So glad to be with you guys today. A little bit about myself. I was actually born and raised in Benton, Arkansas. Had a little different path to medicine because after high school, I went to West Point and graduated from West Point and majored in aeronautical engineering. And from there, served 5 years in the infantry. I jumped out of airplanes. I actually commanded a Special Forces A team for 2 years at Fort Devens, Massachusetts, in 10th Group. And then from there, after I left active duty medicine and went back to reserves, then I came back home to Arkansas and went to University of Arkansas for medical sciences. Then I rejoined active duty military and trained at Triple Army Medical Center in Honolulu. So I spent 12 active years in the military and 8 reserve years in the military and have since retired. I have practiced the last 5 years at Arkansas Heart Hospital. It's been just incredible, the facility and the doctors and the staff. It's such a unique environment. It's been the highlight of my medicine career is to be here at Heart Hospital. So as you said, I'm a general surgeon, so I do lots of things here at Heart Hospital, and trying to pick a topic was interesting. And so with LifeQuest and all, we selected on colonoscopies. Now I know it's a sort of a different topic, and I do have a 14-minute video from a presentation that I had a couple of years ago that's may not be the best topic after lunch, so I'll give a little forewarning of that, but I think it's very informative. It's not as bad as you think, and it's very, very important. I have, as a general surgeon, I do have a couple of passions. One is breast cancer and colon cancer. I think those are two cancers that can be detected, can be prevented, or can be found at an early age or early time to treat it. And I think that's very, very important. So I hope LifeQuest listeners will listen and make sure that they're aware of colon cancer and how they can prevent it in their lives, and also family members' lives. So again, a little, I don't think the movie's as bad as what people will think it will be. And I don't think it's that squeamish, but I'd like to now start this 14 or 15-minute video. I think it'll give a good introduction to colonoscopy and may generate some questions.
Okay, I'm going to start this important topic right now.
Leah, don't forget to share the computer sound. Thank you.
I am.
I have is to early prevent or to prevent colon cancer and also identify and treat early breast cancer. Why is that? Colon cancer is the second most common cause of cancer-related deaths. It's estimated that over 135,000 new cases will be diagnosed and 50,000 deaths will occur in this year. And in the year 2014, is estimated that 1.3 million people were living with colon and rectal cancer. Colon cancer makes up roughly 8% of all new cancer cases, and approximately 4.3% of all men and women will be diagnosed with colon rectal cancer in their lifetime. What are the risk factors? Personal history of polyps or colon cancer, family history of colorectal cancer, drinking 3 or more alcoholic drinks per day, smoking cigarettes, obesity, and I want to emphasize age 50, you are at an average risk to develop colon cancer. Signs and symptoms, although early colon cancer and especially right-sided colon cancers do not have many symptoms, if you have a change in bowel habits, a 2-week history of diarrhea, constipation, or feeling that bowel doesn't empty all the way, of course, blood in your stool, vomiting, unexplained weight loss, and fatigue. So there are several screening methods for colon cancer: fecal occult blood, fecal immunochemistry test, stool DNA, barium enema, the virtual colonoscopy or CT colonoscopy, sigmoidoscopy, and colonoscopy. It is my surgical bias, I guess, that colonoscopy is the only diagnostic and therapeutic and best test for examining the entire colon, identifying and removing precancerous lesions. Can I have the first video? There's no audio, just the video. And I can't see it from here. Okay, sorry. So it's what is a colonoscopy? It's a medical medical procedure to see the entire colon and rectum. We can take a coloscope and go all the way through the cecum. Also, we enter the small intestines and the terminal ileum. The scope itself is a very technical device. Okay, I see it over here now. Technical device. It's very neat that it has a high-definition video camera that attached to a high-definition screen. It has a light. It has a water jet. It also has the air-water suction jet, also an instrument channel that allows various instruments that we can run through. Welcome to the stage, Lisa Young. When she's not Vanna White, she is one of the directors at, let me have the gloves on, doesn't it? She's one of the directors at our GI clinic. Lisa and I, over the last 4 years, we've done just about 5,000 procedures. So without her help, we could not accomplish this. So I thought it'd be interesting, what we can see is show what a colonoscope looks like. It's not to intimidate, but I want to show and educate. Most people will not be able to see this part. We'll get it out. So as you can see, it's not to intimidate, to be very. Colon is about 4 to 6 feet long, so we must have an instrument to get there. You've seen the tip, and it has lots of capabilities, but we also have the driving in. As you see on the camera, we have dials. The dials will let me go up and down, left and right. It can be very flexible, actually do a candy cane and look back at itself. Also on top of the device, there's trumpet-like buttons. If I put my finger over one of the buttons, then it insufflates air. If I push down a little further, what it does is irrigate water. Then there's another trumpet button that I push down, and it can give suction. Then also the instrument channel that we can, there's multiple devices that I can go through and use this. During lunch, we started talking about YouTube videos, and on YouTube videos, Katie Couric actually shows her doing a colonoscopy, even the cable guy. So we thought with Dr. Murphy talking about entertainment, Dr. Robinson talking about there's no I in team, that we thought that one of our MCs would be great if one of the MCs would have a live colonoscopy and they video through it. We have a gown here. Will Dr. Robinson please come up? Well, Scott, I guess you were right. He's not a good candidate because he is full of it, right? How about video number 2? I may move over here so I can see it. This is actually an actual video of a colonoscopy. The patient's already lying on his side. He's got great anesthesia. What people see initially when they what great pictures we see. The high definition camera and video shows very well the colon vasculature. You see the vessels here. Usually it takes about 5 to 10 minutes to go in the scope. I've edited this video to about 1 minute. But as we're going through, you can see that the colon opens up very well. You have very good visualizations. Of course, I for bowel prep. But as we go through, we don't look at detail as much as trying to get there. In a minute, we're going to get all the way to the cecum. Once we get to the cecum, you're going to see a pool of yellow fluid. There it is here. And once we suck the fluid out, you'll see the appendiceal orifice, so we know we're at the cecum. There's the appendiceal orifice in the middle. Then if you go back from the appendiceal orifice, if you look back about the 8 o'clock position, you're going to see a hole. This is the terminal ileum. We'll actually go in the terminal ileum, and you'll see the mucosa change. There's actually some villi. The villi are what causes absorption in the small intestines. I think here in a minute you'll see it. We'll freeze. You see the villi of the small intestines. The most important part of a colonoscopy, in my opinion, is withdrawal. That's where we really carefully evaluate and look at all the lining of the colon. Generally, we take about 6 to 10 minutes to withdraw. As you see, again, this is a very good bowel prep that I'll show you. We'll show some examples in a minute that the bowel prep may not be as good. But again, you can see very clearly that you can see all the layers and vessels of the colon. If you'll notice the little blue fingers, this is a new device that's added about 3 years ago that as you go in, the fingers collapse. As you come out, they expand. And if you notice, they're helping hold the folds open. It has really dramatically increased the amount of polyps that we see. Talk about that when we get to polyps. But you'll see as we pull back, you'll see these fingers as we go around. If people have done colonoscopies before, they know that sometimes it's hard to get around the folds. The folds hide the polyps. But if we pull back slowly with the fingers, it really helps. So again, we're going back slow, meticulous, a great view. It's really unbelievable how good the high definition visualizer is. As you notice, as we coming closer to the rectum, the vessels increase in number. That means we're getting close. What we do when we get to the anus, we actually rotate the scope and look back at ourselves with that candy cane approach so we can see the rectum and the anus and look for any other problems low down. So again, you see the bubbles flow. The light, the little white specks you see, that is actually reflection of light. That's normal. But again, you see a very, very normal colon. We're about to do that candy cane maneuver with the coloscope. And there you see the black is a scope looking back of itself and the roids. This is just a little clip. Sometimes going in, you come up with diverticulosis. If you look here, these outpouching, this is us maneuvering carefully around, trying not to go and injure the bowel. But you get a flavor for this is not quite as easy as the straight tunnel that we saw before. But see the outpouchings. Then we always talk about the preps. Some preps are better than others. I have a couple of clips coming up. This young man had watermelon and ate the seed. So you see the watermelon seeds here, a couple more seeds there. My next lady decided to eat blue Jello. Blue Jello is not the very best method for your bowel prep. Can I have my next slides, or I guess I control them. So I really want to talk to you about colon polyps. That's really the emphasis of my talk. Colon polyps, there's a normal growth in the wall of intestines. It also, some people say it's a natural part of aging. Most polyps are small and benign, but they do require intervention to remove. Removing polyps reduce the risk of cancer greater than 90%. Of these polyps, close to 2/3 of them are adenomatous. They're considered to be pre-malignant depending on the size and number. But again, less than 10% of all these adenomas become cancer or detect them early. But the most important thing to remember is greater than 95% of the colon cancers develop from these adenomas. So it's very important for us to identify them and get them out. Risk factors, one is number. If you have 1 to 3 polyps, you have a low risk. Over 3, it's a higher risk. If you look at the size, again, remember 90% of the polyps we see are less than 1 centimeter. So the risk is 1%. As these polyps grow, then the percent of cancer rises to all of a sudden 4 centimeters is a 90% risk. Can we have video number 3? And I'll go back over here. This is going to be, this is a 2 to 3 millimeter polyp that we take out. There's several ways to do it. This way is a snare polypectomy. We grab it with a wire loop, we pull it away from the thin wall, we apply our electricity, and we take the polyp out. Then we actually retrieve it and send it to pathology. Again, as we look, there's lots of smaller polyps. This smaller polyp wasn't big enough to capture with a snare, so we'll actually burn it or ablate it with electric artery. You'll see the snare come out. We'll touch the polyp and ablate it. Then we can turn around. There's another smaller little 2 millimeter polyp below that. Again, what we'll do, we'll use the snare. We'll snare the polyp. Again, we'll pull it away from the colon wall, apply electricity. Lisa will squeeze down and take the polyp off. Then we'll capture it and send it to pathology. While we're talking about polyps, and probably when we first started doing we talked about polypectomy rate is about 25%, 1 in 5. However, I think with the high definition cameras, with the little fingers we talked about, with the bowel prep, with taking 6 to 10 minutes out, we have really increased the polypectomy rate. It's now monitored. Lisa tells me in 2016, we have over a 60% polypectomy rate on our patients. So I think this really dramatic. I'm not sure if it's because of our diet, but I think it's more because of the high definition and the ability to do it. Again, I'm going to go through several polyps. This is a little bigger polyp. Again, same procedure. We're going to snare, apply the electricity, move it, and then we'll withdraw and take it into pathology. A little bigger polyp, a little more angry, probably about 3 to 4 millimeters. Again, pathology showed this to be an adenomatous polyp, not cancer. But again, we'll take it away from the colon wall, put it in the middle, apply electricity, slowly squeeze, and remove the polyp. This is a little pedunculated polyp. Again, same way, only we want to make sure we get to the stalk. So again, we're going to use a snare. We're going to snare, push down, pull back on the stalk, apply electricity, and we're taking the polyp. This polyp showed we couldn't quite get it out, so we had to suck it up, if you don't mind. Sorry about the queasiness. But you'll see the suction, and we'll suck it right in the... No, take it off. This is a little bigger polyp. We're getting a little bigger now. This is in that centimeter, probably about centimeter range. Again, we're going to do a snare biopsy again. We're going to put the snare around the polyp, snug it down, make sure we're at the base or stalk, electricity, and we'll make sure the polyp comes off. Quickly, some polyps can't be moved by the scope. This is actually a specimen where we've opened up I've taken out the operating room. You see the terminal ileum here. We have splayed open the entire ascending colon, and there's actually a little polyp that was in the base of the terminal ileum. But the major one was this big pedunculated polyp, had severe dysplasia, and that could not be taken out by colonoscopy. Thought I'd show you a couple of anastomosis. This is an anastomosis I did a year ago for cancer. You can actually see we do a staple anastomosis. When we washed this off, we had one little staple that hadn't come loose, but you see a nice anastomosis. This is an iliotransverse colon anastomosis I did about 3 years ago. Look in the right upper quadrant, you actually see the ileum with peristalsis. Did this about 3 years ago for a cancer. Again, this was surveillance colonoscopy. This next is another ileocecal transverse colon anastomosis that we did probably about 6 years ago. This is one of the 2 cancer cases I'll show you. Again, this is cancer is almost completely obliterating the intestines. You actually sort of blue hue around the edge. We actually do tattoos of that, so when I go back and do the operation, I can find it easy from the outside. This is the last case. Again, you're going to see as we pull back, you're going to see the polyp there, you're looking there. That's just the tip of the iceberg. As we pan back and we wash, as we look around, there's going to be that abnormal bulge to the left. And also a little further to the left, you're going to see another little area that's very suspicious in red. This young lady We did this scope about 2 weeks ago. She had her surgery a week ago Thursday. We had a good, clean resection, but she did have 5 of 17 lymph nodes were positive for cancer. So she'll get chemotherapy, but hopefully that'll be successful. As we pull back here a little bit, you'll see the entire left to right, we're going to freeze there. But this was a colon cancer. One of the last things I want to talk about is, well, when do you get a colonoscopy? Make sure it's very important that everybody in the room knows. If you have an average risk for colon cancer, and that means if you're 50, you have an average risk. Everybody should start their screening at age 50 and repeat it every 10 years. If you have high risk for colon cancer, you should start at age 50 or 10 years younger than when your family member had the breast cancer. I.e., if your dad was 55 and had colon cancer, you need to start your screening at 45. If your mom had colon cancer at 40, you need to start your screening at 30. And then the frequency, sort of, we don't go 10 years, it's sort of 2 to 5. I do that individually based on your family history, on the number of polyps you may have had, the type polyps you had, size, number, those kind of things. But it's individualized, but you may not have it every 10 years. It may be more frequent. The other type colonoscopy, if you have any signs and symptoms that we talked about earlier, the rectal bleeding, the new onset diarrhea, constipation, you don't wait for screening, you don't wait for interval, you do get another colonoscopy. You get a colonoscopy to evaluate that at that time. My last slide is my first slide. Hopefully that just in this short time that I've taken away some of the mystique or maybe some of the fear of having a colonoscopy and the importance that it is. We do it all the time and it's very safe and it's something that you need. But please, please, please don't let you, your family, or your patients become one of these statistics on this slide. Thank you very much.
Okay, well, hopefully that wasn't too graphic. I think it was to me, it's educational. I hope to the LifeQuest group, it was educational and informative and not too bad. I guess at this point, I'd like to open up for any questions that y'all may have. I'm not sure how the Zoom works, whether we do it by chat or whatever. I'll let the LifeQuest folks figure it out.
We're open to, if you have a question, go ahead and unmute your mic. I do have a couple in the chat, but I'm going to see if any of our participants have a question first. Thank you. Colon cancer is not funny, but if you were watching my face, watermelon seeds are funny. Colon cancer is not. So I want to differentiate that. Who has a question for Dr. Dixon? Dr. Dixon, you're there you go. We can see you now. Go ahead and unmute your mic and ask away.
I have one, Leah. This is Joe.
Joe.
Dr. You said 1 in 5 rate. I couldn't catch up. 1 in 5 is cancerous. Is that what you're talking about?
No, ma'am. 1 in 5 will have polyps. And
will have polyps. Okay, I wanted to make sure on that.
Yes, ma'am.
Dr. Dixon, when a polyp is removed, do you have to remove the whole tube each time you take a polyp, or can you keep going once, as you move along through the system?
Yeah, you want to take all the polyps at one time. Instead of, if you have, I guess your question, if you have 5 polyps, you certainly wouldn't want to do 5 colonoscopies. You want to do 1 colonoscopy and we take all 5 out. I have taken as many as 30 and 40 polyps out at a time, which adds a lot to the procedure. Most of the time, people have 1 or 2 polyps.
Okay. My dad had diverticulitis and had quite a section of his colon removed. I'm wondering if others have had that in the room, or if there's any particular way to avoid that for myself. Am I frozen?
I think she asked you a question.
Okay.
Yeah, I asked a question about diverticulitis.
Okay. Yeah.
About
So
how to avoid.
Yeah, you saw the picture of diverticulosis, and most people in America over about 35 has diverticulosis simply because we don't drink enough water and eat enough fiber. And so sometimes the diverticulosis can become infected, and that becomes diverticulitis. And then when the infection goes away, it goes back to diverticulosis. The way to prevent diverticulosis is increase the water and increase the fat. Excuse me, not fat, fiber. So increase water and fiber.
Yeah, gotcha.
I have a question. I'm Bernadette. Regarding the colon cancer, my dad, his sister, and his mother had colon cancer. My dad, he's doing fine, but he had a large portion of his colon removed. He's on a bag right now, but he's alive, and he goes back for tests for any cancer. And I do get tests. I actually had my colonoscopy last year. My question is, when, and I have a brother who did have some polyps removed. What exactly are if they're not cancerous, what are they made up of?
Well, yeah, they are growths. Okay, and a lot of people do have that as part of the colon itself. As we said in the different type polyps, that the adenomatous polyps are the one that are precancerous. Some people will say it takes most polyps 8 to 10 years to turn into cancer. That's why we do the 10-year rule on the normal polyps, but it also depends on the number of polyps, what type polyps. Well, I didn't really go over that in the video, but you saw the pedunculated ones. Some are large ulcerated, some are sessile or actually grow on the polyp on the wall itself. And then there's, instead of adenomatous, there's tubular adenomatous, there's sessile adenomatous. All those, as I'm deciding when you need your next follow-up colonoscopy, that has a bearing on when we do the next colonoscopy. Does that help? I know that sort of stumbled around your question.
No, that's helpful. That gives me some ideas. So I appreciate that.
With the family, if you had a family history, I certainly would do one every 3 to 5 years. And all those factors include, what type polyp, how old you are, and many things that go into it, how soon I would have you do a next colonoscopy.
Okay. Yep. My last one, like I said, it was last year and it was good. I've never had any problems with the colonoscopies. I did have, let's see, in 2013 and 2014, I did have the sloughing of the lining of my intestines. They didn't really know what was going on, but it was pretty serious enough. I was in the hospital on 2 occasions. So, but there was no cancer found.
Okay, maybe it's some type of colitis. Yeah.
Yeah, it was pretty bad. But so far everything's good. Everything's good.
Well, good. Be careful and be safe. Make sure you drink plenty of water, eat plenty of fiber. You need 25 to 35 grams of fiber per day, and follow your colonoscopist's recommendation on when to have the next one.
Yes, I do. So it's almost like a bread and water diet. Not quite, but thank you.
Dr. Dixon, you had mentioned that there are certain preps that are better than others. What constitutes a better prep than the other, and can, as a patient, we request one over the other?
No, ma'am. There are several preps. I really don't care which one we use as long as it's good and there's no residual left in. People do have problems. Certain people have certain problems with certain preps, but I would say 95% of the time, whatever prep is used, if you'll follow the directions, it will be adequate.
You mentioned that when you spotted cancer, you said something about you were able to tattoo. I'd never heard of that. How do you do that? That's
yes, ma'am.
clever.
In the instrument, you have a needle, and really you just inject methylene blue. You stick the needle out in the mucosa and you tattoo it. It helps several times. I use it for cancer so that when I go in
from the outside, I can identify very easily where it is. Sometimes I'll have a very sort of suspicious polyp that may not need to have surgery, but when I go back and look at it in a year or two, I can see the tattoo and I can visualize where that is to see if there's been any regrowth or anything like that. So it's really helpful. But it's methylene blue. It's just a needle and injection.
That makes me think about the nerve endings. I guess there aren't as many nerve endings necessarily in the intestines as in the epidermis or other places. So people aren't aware they're getting a tattoo because they're asleep, for one, but.
Well, also there's no sensory nerves in the colon.
Okay.
The sensory nerves pick up in the rectum, so between internal and external hemorrhoids. You can do bands on internal hemorrhoids because you don't have any feelings, but you can't do bands on the external because it does have feelings, but no feelings in the colon or sensory nerves.
Okay. And earlier when you were talking about removing polyps, do you have to remove the entire tube after each individual polyp? So like you have to go out with the tubing, or does it get suctioned in that black tube that has the medical instruments in it?
Yeah, normally you don't. If it's a large enough polyp that won't be sucked out, you can actually take the snare and make little pieces out of it. Small enough to suck up. There are occasionally there's a large polyp that you have to snare and pull it out and go back in. We try not to do that, but it depends on the size.
Are there ever times where you come across such a cluster of polyps that you determine it's better to take out that small portion of the intestines? And how do you decide how many portions or how many polyps are too many?
Yeah, and it's really as a judgment thing. If you know the colon wall is pretty thin, so if you start taking a big chunk of the polyps out, you could go through the wall, and then that would cause a surgical emergency. So it is sort of judgmental, but a lot of times the polyp may be so big, it may be so clustered, it may be, we talk about a sessile, so it's not little on that little stalk, that it is better to take the whole colon out and go to surgery. But of course, people would much rather do it if you don't have to do the colon resection.
And I personally had one more question. We have heard some symptoms related to COVID that are related to your colon. Are you seeing any of that in your medical practice?
I have not. It has been reported, but I've not had any pathology that has the COVID. And actually because most of the colonoscopies are screening, as you know, with COVID testing, we're trying to avoid those screenings. If we do a screening colonoscopy at heart, you have to have a COVID test 3 days before. So we're not seeing many COVID patients. And of course, if you had COVID, we would probably delay the colonoscopy. But I've not come across any pathology that had the COVID. But a great question.
So I had my first colonoscopy last fall when I turned 50. And I think they told me I didn't have to have another one since I have no family history for another 10 years. Is that what you would say?
That's correct. So if you have no risk factors at all, 10 years, 10 years. That is unless you have some kind of symptoms between now and then, but that is true.
Okay. I think we have time for about one more. If we have any other follow-up questions for Dr. Dixon.
How do we keep from coming to see you besides regular maintenance?
For best colon health, drink plenty of water and get 25 to 35 grams of fiber per day. And then, but it's very important to get screening colonoscopies, as we talked about before. Mm-hmm. Don't ignore them.
I have one more question. I'm sorry.
Yes, Bernadette.
It just came to my mind. Regarding barbecuing, I understand that the carcinogens from barbecuing meats can increase the chances of colon cancer. Is that true or false?
Well, I say it's controversial. There's lots of things that we eat that can increase the risk of colon cancer. That is one of those mentioned. Whether there's been a good study that show that, it's sort of up in the air. But it's a good question. One other question I will talk about, some people will ask about the Cologuard test. Cologuard tests are good. If you have a positive Cologuard test, it means you must have a colonoscopy. I like to talk, if it's negative, what do you do? If it's negative, it's very important that you still do the screening as suggested. So just because you have a negative Cologuard does not mean you don't have to have the routine screening colonoscopies that we talked about.
Something that's kind of trendy is colon cleanse. You can see those in, over-the-counter or products or herbal medicine, kind of homeopathic medicine. And I'm just wondering what you think about the effectiveness. Do it, don't bother, worthless, not a big deal, about colon cleanse products.
Yeah, I don't really have a feeling on those. I think if it makes you feel good, you can do it. I don't think it helps any for the colon health. I don't think it would reduce your risk of colon cancer, reduce the risk of colon polyps. It's, as long as it's not harmful, I think it's okay.
Okay. Well, thank you so much for being here with us. We, when we invite someone from Arkansas Heart Hospital, we weren't exactly expecting to talk about this part of the body, but your presentation today, and then Dr. Mark Myers on wound care and the use of a hyperbaric chamber have, expanded our concept of the heart hospital and what your role is in our community. So we really appreciate you today and your message to our members and for our Facebook viewers as well. Appreciate everybody tuning in, and thank you for your time.
Okay, thank you.
Thank you so much, Dr. Dixon.
Thank you.
I see a lot of
everyone.
people, if you can't see them, I see a lot of people applauding and waving. Thank you.
Okay.
Yes.
You can-
Thanks everybody for coming, and you can see this video and direct your friends